Hello, my name is Richard Lewis. I'm a mobile crisis peer support specialist for Eastern Shore Crisis Response, part of the affiliated Sante Group. I have been working out of our Cambridge office for 2 years.
Hi, my name is Amanda Fox. I use they, them pronouns. I am the Quality Assurance Coordinator at Community Crisis Services. Community Crisis Services, or CCSI, offers different types of crisis services, including domestic violence services, homelessness services, and our largest program, which is the Crisis Hotline, which is what I'm here to speak about today. Our crisis line answers for the National Suicide Prevention Lifeline and is a backup for the Trevor Project, as well as other warn lines and crisis lines throughout the country.
Hi, my name is Vicki Scofield. I'm a peer recovery sports specialist at the New Beginnings program at Grassroots Crisis Intervention. We are able to provide screening, brief intervention, and referral to treatment, also known as the SBIRT, along with full assessments, short-term opioid withdrawal management, and peer support. Our program provides a bridge to treatment by meeting individuals where they're at, removing barriers, and offering ongoing follow-up until they are connected to care. Individuals seeking help for any substance misuse, ages 12 and older from any location, can receive free services from our program. We also house the mobile crisis team here for Howard County, along with the 211 hotline, and we also have a homeless shelter. We have a day resource center, which is offsite over in Jessup, Maryland, which offers additional social services for the community.
Thinking about your time working in crisis services and back to that day when you started in your job, when you came in, was there already an awareness of what a peer support specialist is, or what peer support looked like, or how that happened in the crisis services you offer? Or did you have to reset expectations about kind of what your role was and what your expertise was in your organization? And that question is for anybody.
Well, for me, I had to navigate a little bit. I was a peer support specialist for the health department. I worked in addictions and mental health. So going to the mobile crisis, it definitely was a little different. Most of the people that I dealt with, the clients that I dealt with at the health department, was strictly in addictions or co-occurring, more like running a few groups here and there, taking people to treatment, stuff like that. With mobile crisis, it was totally different. You're on call and you never know what you're gonna get, and until the call comes through. So it was definitely different for me.
I think for me at Grassroots, what was interesting is it was a fairly new program. I've been here a year, and Grassroots started their New Beginnings program over about two and a half years ago. And they had some transitions and trying to figure out where peers fit in. So when I joined I was a part-time peer, and I had some previous experience with recovery housing. We were going to try to integrate peers in recovery housing. So I had a lot of exposure to peers, but I didn't actually work with peers. And I don't know that they understood what peers were here in the big picture thing. So it's been a real honor to be able to help, figure out what the peers can do here at the Crisis Center.
Yeah, I would say I've been at CCSI for almost a year now, and Community Crisis Services doesn't identify itself as being an organization that seeks to hire peers or people with lived experience. Basically, they just don't use that wording. But that is very much something that they actively do, which I find pretty amusing. So I would say that I definitely came into it not really sure what to expect as far as one of the things we answer for crisis lines, including the Trevor Project, the National Suicide Prevention Line, things like that. And there's a 30 hours worth of training that everyone goes through and stuff like that. So it's not everyone is equipped on the lines, but it's different. it's different when you have experience of calling those lines yourself, or like you have lived through some of these things yourselves. And what I found, at first I was really nervous about, I felt like, at least in my cohort when I was getting trained, I felt like I was like the only person who had like called these lines before, and I felt weird about being like that person. But then I also had some very strong opinions about different things that needed to be trained certain ways. So I think it was helpful to my cohort, but as I got more integrated into the team, I realized that a good proportion of the people on staff, including the leadership, mostly identify with having lived experience with mental illness. So there's definitely a strong peer group here. It's just, I don't think anyone is super familiar with, I mean, not that they don't know the terms, but nobody's using the terms. So no one's saying that they're a peer support specialist. Obviously, they're not certified, or they would say that, but no one's saying that they identify as a peer. They usually don't use the words lived experience, but they will say something to the effect of like, this is something that I've experienced before. And so I've been having some conversations with them recently about like, hey, this is like actually like a peer oriented space. Like maybe if we used these words when we were looking for people and stuff like that, that could be helpful. So that's kind of where we've been with that.
So that brings up a great question. When you are interacting with folks in your role and you say, I'm a peer, do people know what that means? What kind of reaction do you get, or do you find you have to explain to the folks who are, you know, being served or being supported by your services, like the concept of being a peer? Does anybody have experiences with that?
I mean, I usually go right into, like, I'll say I'm a peer recovery specialist here, and I, you know, have had the same issues like, you know, you have had with either alcohol or drugs or whatever. You know, my particular drug of choice was alcohol. So I don't normally go into a long-winded explanation to the client, especially in crisis services. It's kind of hard to say, oh, I'm a peer recovery specialist and this is what I do, you know. But what I do say is, you know, I've been there. That's why I'm here. I can help you. I can guide you. I can hold your hand, give you that additional support. So now when it's working with my team and I have to integrate my team, that's a whole different, you know, I have to teach them. Not all of them. I don't want to do disservice to my team, because I think they do understand the role of peers now, but you know, just in the general community, it is something you have to explain sometimes.
Yeah, I would say similarly, when I was on the lines, I would say things like, I've been there before, or like, I get it. I've had similar experiences, like I've called lines like this before, things like that. I would say things, I don't think I ever used the specific terms peer. I think because, again, in crisis services, kind of like Vicki was saying, it's like it's very focused on the other person, not you. So you want them to understand that you get it, and then you want to move on as quickly as possible, because you have other more important things to worry about than whether they know what a peer is.
Yeah.
Yeah, that's about the same thing with me. And I've been here for over 2 years with mobile crisis. And I don't think I've ever told anybody that I was a peer. I don't think they would, you know, I just, most of the time, depending on the situation, I tell them, I understand what you're going through. I've been there, very something similar. Because most people, when they call mobile crisis or the police or somebody call us, they're expecting us, they know that we're there to help. You know, so they're already expecting that we do know what's going on, and we wouldn't have been called in the first place. You know, I don't even get the opportunity to sometimes to let them know I'm not a clinician. I don't diagnose. I'm just basically there to kind of hold your hand through this or let you know. Sometimes I even got to let the police know that, look, I'm not a clinician. You know, but I can. I mean, not saying being there for a while, I've learned a lot. You know, I don't have the letters behind my name to diagnose anything, but I pretty much know what's going on.
That's I think a huge part of the power and the potential for peers in crisis services is, you know, a personal understanding, but maybe also an awareness of kind of how to read a situation, or or understand that something someone is doing is coming from a place of, of panic, not aggression, or this person is confused because what you're saying is confusing. It's not that they don't understand what's happening. It's that, like being able to suss out more, like what's really going on there. I would say for Amanda, I think when people call a hotline, they kind of know what to expect. But Richard and Vicki, when folks come when you meet them with services, right, whether they're being brought into a center or whether you're going out to them, do you find that most people kind of know what to expect or know what their options are, or what they're getting into? Or are you meeting a lot of people who are in crisis for the first time, and in addition to whatever's going on, in them, now they got to figure out who these people are and what they're doing? Like, how's that experience going?
For me, we have a crisis hotline also. So technically they're talking to the ops people first. And the ops people basically try to help them out to see if it is a crisis situation where MCT has to go out, or the mobile crisis team has to go out, or they can handle it where the mobile crisis team doesn't have to go out. They can maybe set up a UCC appointment where they can go talk to a clinician or somebody, something like that. But if mobile crisis is needed, then we'll go out. And like I said earlier, a lot of times, most folks, we do get a lot of the same people over, but sometimes it is some new folks. It could be because I can't classify what is a crisis for you. Sometimes a crisis could be that's for them. If they call on that 888 number, it's something. But sometimes, we might not think it's a crisis. It could be a crisis for somebody else, But we won't really know till we get there on scene and see what's going on.
Yeah, so for us here, we have a hotline. We do house the 211 hotline here. So when we get a call and somebody has a substance use disorder, that's where they would call either myself or one of my teammates. There's another full-time peer here. And then we have 2 substance use counselors. So many times, and of course, since COVID, everything's phone, we have very few walk-ins. We used to have, and I started the first day of COVID. So I don't know pre-COVID at Grassroots. I just know COVID plus. Pre-COVID, the walk-ins were a lot. There were a lot, and then it went to 0. So what we do is we have to kind of vet out and see, what the crisis is. Do they have an alcohol use, a drug use, opioid, whatever? And so we see a lot of clients lately that it's parents looking for help for their either children or their adult children. So the parents in crisis, their relative doesn't even know they're in crisis, but the parent is, so we've gotten a lot of that lately. So we don't handle MCT calls. We have a whole MCT division, and they go out. And if there is a substance use disorder, they may refer them to us, but it's kind of like a separate entity, if you will.
Your point about COVID, right? About like how things have shifted and how we've adapted to that. I was Richard or Amanda, have you seen changes in what happens in your day-to-day from COVID?
I would say, again, I started after COVID, so it's different. I would say the call center life has changed a lot, and the fact that you used to have to come into the office and take calls at a stationary, like at a phone that plugs into the wall. They used to have those. And that's not the case anymore. At this point, we have specialists in Hawaii, we have specialists in Washington State, we have specialists throughout the country. So it looks very different as far as like what the day-to-day looks like, just because we're not communicating in the office. We like communicate over platform Slack. We have we've been like constantly expanding the amount of specialists that we have to try to meet the need, because the call volume has also increased. I haven't run like stats on it, so I can't tell you for certainty that that is true, but I did once look at last year's numbers versus this year's numbers, and they were higher. So that's, but I did not see if that was statistically significant. But I would say that we, because we also answered 211 here, and then mental health calls in general have also gone up drastically. So COVID definitely is a lot of stress for a lot of people. So the hotline is very busy. And we have a good proportion of people that call mention COVID in some way, shape, or form. And we track that to attempt to identify funding sources and things like that. But the reality is that the volume has just drastically increased.
Yeah, it has been a lot different since COVID, but because it changed our whole organization up. Our whole call center was at the office. Now our whole call center, they work from home. To go out on a call, we have to do COVID screenings. You got to do a COVID screening before you even go out. We do a lot more telehealth now. Now, for me, being I work overnight, most of my calls, technically, I only go out most of the time now if it's police involved. The police call and they need me, then I really don't have a whole lot of choices but to go out. But we still have to do the COVID screening and all that stuff like that. And just like you guys were saying about the substance use, since COVID, we've teamed up with Caroline County Sheriff Department, and we're partnering with them with a safe station. So we've added a safe station in the last couple of months to our repertoire that we're doing. So with COVID being lifted a little bit, like I said, we've been doing a lot more telehealth and a lot more parents with children calls, because a lot of the kids are home, don't want to go to school, don't want to do this and that. But that's what a lot of the calls have been here lately, in the past year.
Can I ask, because I think safe stations are not in every community. Can you talk just a little bit about what that is? Well,
a safe station is a place, when I first heard about it, when I was working with the health department, Anne Arundel County has a safe station where someone who is on drugs, who are using them, just fed up, they can go to the fire department and turn themselves in. Whether they have drugs on them or whatever, they will take them and they will get them into treatment within a day, 24 hours, 36 hours, whatever like that. They will help them with their court dates and all that, like this and that. On the shore, it's a little different because our fire department's a volunteer. So, and the safe station that we are partnering with, Caroline County, is based out of the Sheriff Department. So they would have to go to the Sheriff Department and do the same thing. But with us partnering with them, technically they partner with the peers. We're in the process of hiring peers. So if somebody come there and they want to turn themselves in, they were also working with the state's attorney's office, where they won't be charged. So people know we try to inform people what the Good Samaritan law is and stuff like that. And we basically try to get them in a crisis bed somewhere.
Awesome. Thank you. Thank you. Thank you. It's a very cool model that, we hope expands more broadly. It also makes me think about multiple folks talking about the ability to, de-escalate or resolve a crisis, before it gets to the point of, for instance, involving law enforcement. There's a lot of talk happening, local level, state level, national level. We know that when law enforcement is the first or only type of crisis response that's available in a community, not only do folks not get the support or the services they need, but there can be really terrible and deadly consequences for that. And something I've heard, kind of research and statistics, Amanda, to your point, looking at is that when peers are involved with crisis services, whether that be, in a hotline or in a mobile crisis team or in a neighborhood, crisis center, that so many situations are able to be resolved, like de-escalated or resolved or diverted. And in part, it's because of peers understanding when someone is kind of talking out what's going on with them, and like when we need to take further action to help someone be safe, and when is it just part of processing. And so I was wondering if anybody wants to speak to that, about how you feel like the services you provide help people get what they need without kind of getting into more intensive situations, or maybe more situations where there's less choice involved. Anybody want to speak on that?
Yeah, I would say it's really important in hotline work. I think it's one of the most important roles that like peers play in a situation is people who have lived experience with mental illness are a little bit more understanding of what the process of being hospitalized forcibly or not so looks like. They have a concept of the fact that it may or may not be helpful for each person, whereas like people who have no experience with the system will sometimes just be like, oh, go to the hospital, everything will be fine. And that's definitely a thing that like a lot of people think. And I'm not saying that everything won't be fine if you go to the hospital, but I am saying that it's not always all fine if you go to the hospital. So when people come into this work and have the lived experience, there's less of a panic around suicide, particularly, is like one of the big things that like sometimes people hear the word suicide and they're like, oh my God, they have to go to the hospital right now. And that's just really not the case most of the time. Like most people can do effective safety planning over the phone. They don't even necessarily need someone to come out to them. You just need to de-escalate them, talk them through the emotions that they're feeling with right now, give them some words to describe what they're going through, and make a safety plan. And so I think that one of the things that makes peers like really essential to this work is just the lack of panic around serious issues that like Richard said, we can't say what a crisis is to anyone else, right? A crisis is something that like you experience for yourself. It's kind of like trauma in that way, right? Where you can't say what's trauma to someone else. You can't say what a crisis is to someone else, because it could just be they are in crisis and the last thing that happened was they locked their keys in their car, which like who cares? But the 27 things that happened before that were massive, or like something happened, or they've been building day by day and day and day, and they haven't been being able to receive the services or help that they need. And so just the idea of not panicking, I think, when you hear things that sound kind of scary to the average person is really important. And the idea of having an understanding of how the systems might work. So like options that are available, because a lot of people think that like the only options are like outpatient therapy and the hospital, right? A lot of people think that. And so knowing that like there are different levels of care that you have more or less choice in, and these are things that we can explore with you. Like you don't want to go to a therapist's office. Well, video therapy is way more of a thing than it used to be. And like there are way more options than people realize. And I've noticed that peers are more aware of like the plethora of options that there are than just like the average person. Even if you try to train them, navigating systems is pretty difficult for people. So like people who have experience navigating the systems navigate systems a little bit better.
Yeah, I think that was really well said, Amanda, because I think, for those that have behavioral health issues, whether it's a mental health crisis or a substance use disorder, navigating those systems when you're in that crisis is almost impossible. But for those of us that have done that, we know it is possible. So we can give them that hope. And there are, as we like to say, multiple pathways to recovery, whether it's a mental health issue or a substance use. And, I used to think my way was the only, when I came into early recovery, it was like, you have to do it my way. I wasn't a peer. I was working out in the secular, the basic secular world. And, I was going to save the day the way I got recovery. But now I realize, my story is my story. It's not your story. And I want to help you make your story. And I'm going to guide you along that path. But there are so many different pieces. And like you had said about that, their tipping point might have been they locked their keys in the car, but they locked their keys in the car because they just found out they lost custody of their daughter or something. You don't know what happened before that last event. And so I love the fact that we can come alongside them and help guide them through whatever that crisis is.
Well, for me, and you're all right, especially about the lived experience, but getting the requisite trainings that when you was talking about working with police and stuff like that, we do CIT training at facilities, and we train a lot of the officers on Eastern Shore. We train a lot of the correctional officers on the Eastern Shore also. So a lot of the officers that I deal with are CIT trained. And part of the CIT training, one of the most important things that I've got across is the mental health first aid and the youth mental health first aid. It's helped me a lot because I was kind of blind really to the mental health side. I've also have worked at Eastern Shore Hospital, which is also can be like a crisis situation, which is totally different where I'm at now and totally different from the health department. But being trained and having that knowledge so you don't panic in different situations is very good.
Speaking of that training, for folks who are, who are listening to you speak and hearing the idea of like, oh, I could use my experience to really help someone else, find recovery like I did, or avoid, a situation that I ended up getting into that I wish I hadn't, or maybe I could have avoided if someone had been there with me. For folks who are thinking about getting into working in crisis services, and we know that, we see the job postings come up, folks looking for peer support specialists. What kind of training would you recommend that people go through themselves, or experiences maybe that they have to kind of see whether this is an environment where they think they would work well?
Well, there is, in the state of Maryland, there is a certification board for peer recovery specialists. So you can get certified. Most positions, I believe, if they say if you want to come on board and be a peer, you need to get your certification within like 6 months to a year. Some don't require that. But that would be the first step. Like I'm getting my certification right now. I'm very close to getting it. And there's 4 domains. There's domains that you have to go through, like advocacy, mentoring, and education, and different things that you have to do. You have to write your story. You have to get letters of recommendation. You have to put in 500 hours worth of peer services. So there's a lot of credentialing. And what that does, though, that helps us higher the bar, raise the bar so that we are seen as a viable commodity within the behavioral health environment, where I think often peers are seen as less than. They don't know what the job is. What's your qualification? Qualification is training with experience, or experience with training. And that's how you can get it. That's a first step.
Mm-hmm. Yeah, another training that I did recently that I found super useful, that I think people might be interested in as just as like a suicide prevention thing. Also, if you were to ever come work at CCSI, you could get trained in this for free, but if not, you would probably have to pay money. I have no idea how much it costs. But there is ASIST suicide prevention program, which is applied suicide intervention skills training. And I found that super useful. I will say that the majority of mental health and or suicide trainings that I have sat through in my life, I'm like, this is stupid. I could teach this better than whoever's teaching it. Like, maybe I'm really judgy, but that's usually how I feel as a person who's come through like most of the system. And I went to it kind of expecting like, and it was actually, I was like, oh, everything, like, this is very much on point. Like, this is very much something that I think it makes a lot of sense. It just teaches people how to like, navigate the topic of suicide a little bit more effectively. So I think that's a really awesome training too, if you're interested in that. And mental health first aid, like
Right.
Richard was
Mhm.
saying,
Yeah.
is a good place to start if you're not sure, if you don't have a lot of experience, or you're not sure if you'd be interested at all. Like if you don't want to go and get certified in something before you're really sure, like mental health first aid is like a good like beginner overview of like just like the very basics to start with, I would say.
Mm-hmm. Yeah, that training you was talking about with the suicides, we take a CISM training here,
Mhm.
and it was pretty good. And like I said, the mental health first aid, and depending on what organization you work through, each year you got to go through. When your year comes up, you got to do like maybe 20 or 30 different trainings,
Mhm.
and you got to really certify yourself every year. And it all the way down to just driving, a
Mhm.
driving class and stuff like that. So they make sure that you always on top of your game. If you're going to work in this field, it's not like just because your lived experience is good, but you're also going to get some on-the-job training, and they're going to make sure you stay on top of your games, and you'll continue to learn.
So
One thing, if I can just add in, I apologize. With the certification in the state, another requirement is 25 hours of supervision from
Yes.
a supervised peer, which I love. I have a supervisor. I've done my 25 hours. I'm not giving him up. He's mine for the long haul. And the reason being, it's very similar. You know, you hear, you know, the social workers or, you know, any counselor has to have supervised hours. And we think, well, wait a minute, what about me? Well, peers do if you want your certification. And they are a great sounding board. They're your peer, which is great. And they help you kind of reach your goals and keep you on track. So I love that about that program.
So can I ask, kind of to the idea, Richard, of like staying on top of your game, right? Like really being, staying up with what's the cutting edge, you know, what are best practices? What are new ideas that are emerging? We are still learning so much about how the brain works, about how memory works, about what trauma does, you know, for a person, and this idea of, you know, of neuroplasticity, that we can heal. Like, I think that's one of the most important things that peers bring to the table in crisis services, is the awareness that recovery is possible. Like you can find healing, and there's a whole community of people here ready to support you in healing your, you know, your heart and your soul and your life. And then Amanda, your point about going through trainings and thinking, well, you know, that's fine in theory, but in practice, it actually goes like this. What is missing right now in the world of training? Like, what are things that you are seeing people who are involved in crisis services, or folks who are working as peer support specialists? What are the topics that no one is talking about that are really important that we start to address in a different way to help kind of move, you know, help our system continue to evolve in behavioral health?
Racism. Sorry, that's very broad. I would say, I mean, I think that there's beginning to be a conversation about racism, like the patriarchy, other forms of oppression. I think that it's coming up a little bit at this point, but I think that one of the things that the field of mental health and behavioral health has left out for too long is the fact that like systemic oppression is very real, and it affects people. So like one of the things is like they did like the ACEs, like the adverse childhood experiences studies. They did like the children who have traumatic experiences grow up and they have negative health outcomes across the board. Then they had to go back and do it, including things that weren't just like individual traumas, but were like collective things. So like living in poverty, like being racially discriminated against, like things like that. And they added, and all of those things, which are also traumatic experiences, contribute just as much as like the individual ones. So I think that part of it is that like we're such an individualistic society that everything is about like me, and like I think that's part of it. You don't want to think about that there are things that are like way bigger than individual people that are affecting people, because that's a lot harder to change, right? But I think that like as someone who like doesn't fit into the gender binary, I think that like I'm aware of how like systems can really affect things. And I think that it's a topic that makes people uncomfortable, and therefore people are less likely to talk about it. And so I think that, and then I will also say that I think that the training that exists around suicide, or the amount of training that exists around suicide, is lower than it should be, with how high of a death rate, like with like the mortality rate of suicide, and the like it's one of the leading causes of death for like most age groups. So I would say that too, but I would say like that the main, the first thing that came to my head is like systemic issues like racism, I think, are huge. So
I was part of a group. Vicki and I met as part of a nationwide learning collaborative around peers in crisis services. And one of our peers out in Ohio made this great point about little a and big A advocacy, right? So like in our role as peers, as we're supporting each other, advocating for ourselves, for our needs, for our rights, advocating for our peers, needs and rights, but also as a community of people with lived experience. And each of our lived experiences is intersectional, that all of the identities that we carry are, our family history, our cultural history, our neighborhood history, our personal history, all of those things impact how we move in the world. But we share this thing in common of having been through a really tough, tight spot in our lives in some way, and finding our way through, often with someone else, helping sit on the other side saying, you can make it, like, come on through, come through. So it seems like we, as our society over the last year, has had to really reckon with things that we haven't before. There is no business as usual. COVID has really changed so much of how we interact. And we've all had some time to reflect on and listen to the voices of people who have not always been listened to. And so I wonder if there's a great opportunity for us coming together as a community and saying, in healthcare, this is what we need. We need our healthcare to be anti-racist. We need it to be trauma-informed. We need to see people who look like us or have been through our experiences helping, and being helped, and that there's a community support piece here. And how do we advocate not just for what we need in this moment, but for everyone coming after us, right? And a lot of you were speaking about parents and their children calling, for adult children or for children. And so I guess kind of as we bring this together, do you have any thoughts about, over the next 5 years, where you think the biggest opportunities are for peers working in behavioral health, in crisis services, or just behavioral health in general, as our whole society kind of recovers from this crisis situation of COVID?
The one thing that I'm always reminded of, and this is more of the little a than the big A, but I think the little a is always going to impact that big advocacy piece. We have to start with our own stories and then make the big story. And for me, it's really just to remind peers that their story is going to change, that their recovery is going to change, and I think I may have talked about this in that collaborative that we were on. Like when I first came into recovery, I had an alcohol problem. I'm pretty far removed from that now. That's 12 years ago. I mean, I still remember it. I still, I can still feel and empathize, but now my story is grief and loss. So I think we as peers just have to remember that our stories are always changing, and that we need to share that when we can, but in crisis, in crisis environment, it's hard. So I try to remember what it was like back 12, 13 years ago when I was in active alcoholism. And sometimes it's really hard. So I like being in the crisis center because it reminds me that I'm that close. I'm still that close, even though I'm that far away. It keeps me, I think, a lot more humble than I probably would be if I wasn't working as a peer. You know, even if I was still in recovery, but not as a peer. So I think we have a huge opportunity to share our stories in more collaborative type environments like we had in that learning environment that we did. I love being able to share cross states, across the country, see what others are doing, because there's so much good stuff happening out there that we don't even know about. That we can apply, because I know Maryland has a really strong peer community or peer, you know, peer services, if you will, but I don't know what Prince George's is doing, you know what I mean? Even though we're all here on this Zoom call right now.
Anybody else?
I would say, I think it was like last year, 988 got passed. And so, I think in 2022, 988 is gonna be a thing for sure. It is signed into law by the Congress of the United States of America. So it is like not just a theory anymore, it is actually happening. So, one would hope that that would come with a significant amount of funding for such services, because the demand is definitely going to increase, right? Because it's a lot easier to remember 3 numbers than it is to like make sure that you have a number programmed in your phone, or make Google it or something like that. Like, it's not like you can't find the number, but it's a lot easier if you just know the number. I think you're also going to see an increase in the kids that call, because a 3-digit number is a 3-digit number, not a whole phone number. So I think with 988 coming out, there's going to be obviously a huge need for hotline specialists and people to answer calls. I think mobile crisis is going to need to be, like, I think all of these things are going to need to be expanding. Like you said, behavioral health services in general, I think we're finding that there's really a shortage of therapists that'll take insurance at this point, because people are trying to go to therapy, and there's only there's a finite number of therapists, and there's a smaller finite number of therapists that take someone's insurance. And so there's definitely going to be spaces in which places that maybe have been closed out to peers so far because of stigma or lack of ignorance or lack of funding, I think might start to open up. I think that the longer that peer services have been existing, I think that it's spreading as a more prevalent thing. I know that when I went to college, I did not know that peer specialists were a thing. I probably wouldn't have gone to graduate school. At this point, I'm about to be a licensed social worker, and if I had known that I could have been a peer recovery specialist, I probably wouldn't have gone to grad school. I would have just been a peer recovery specialist, and it's fine. I'm not going to pay the money back anyway. Don't tell the government. They know. I'll pay them some of it, but they're never going to get it all, because I'm going to be poor, because social workers don't make money. But yeah, I think that as there's definitely going to be openings moving forward for peers, even more than there have been. I think that as people start to understand in the health arena and in the policy arena that peers are a thing, I think that the roles are going to continue to expand and expand. So it's not a field that's going out of style anytime soon. I'll say that for sure.
I agree. It's definitely not a profession that's going out of style. It's definitely going in, because one thing in the mental health field that I feel in the next few years that's going to be lifted, like Amanda said, is the stigma. Because especially in the Black community, when I was coming up, I don't even know anybody that went to see went to see a physician or a doctor for any kind of mental health illness, we always say, oh, he crazy, or such and such is this, or such and such is that. But now, I think that it's more prevalent. A lot of people feel more comfortable going to talk to somebody if they need to. And I've referred people to a lot of, like, I refer people whenever I get a chance. I think you need to go talk to somebody. You need to speak to a professional. And it's not as bad as before, because we're like, I'm not going to talk to nobody, but hey, you really need to, because, and now with pretty much everybody has health insurance, that's one of the best things that ever happened. That you want to call it Obamacare, or whatever you call it. Now that people have access to health care, they get the health that they need. You know what I'm saying? Because it seems like every time there's a mass shooting or something, first thing they say, oh, something's wrong with him. He had mental health issues. Oh, yeah, you think? So hopefully in the coming years, more people will take advantage of, and maybe our federal government won't stop trying to block everybody from having free health care or whatever, so people can get the treatment that they need, because a lot of people need it, especially these young kids coming up today, and they're dealing with a lot of stuff that we never dealt with. We never dealt with having to stay home from school. Parents never had to deal with that, losing jobs. Who's going to watch little Johnny while they at school, while they trying to go to work, and they supposed to be at school all day? Who's doing that? Who's controlling that? Not being in class, being around your friends, it's totally different, and it's very difficult.
Absolutely. I mean, I think right along with that is telehealth has been a great resource for many folks, but especially like if you're in a rural area. I mean, I think we're experiencing that on this call. If your cell phone signal isn't, or your internet signal isn't strong because you're in a rural community, or if you're, if you got a track phone and so you can't do video call, you can only do telehealth by audio. The access has opened for a lot of folks, who can now access services in a way maybe that feels less stigmatizing, right, from the privacy of your own home. But we have to make sure that there's investment in services that are available in the community for people to just walk into, right? You don't need a data plan. You don't need insurance. I think for Honor of Maryland and our network of wellness and recovery centers, that's one of the most powerful things. Is anyone, doesn't matter what your diagnosis is, doesn't matter what your insurance status is, you don't even have to give us your real name, but you are welcome to come in and receive peer support at a wellness center. So access, you can't take advantage of all of these wonderful services that we're working so hard to make better. Oh my gosh. You all, this has been an incredible conversation. Thank you so much for your wisdom and your recommendations and your thoughtfulness about, what we all have to be thinking of and looking for opportunities for as individuals, for people, who want to use our experience to help other folks, find recovery or avoid trauma in some way. As professionals in the healthcare, industry, of like looking for opportunities that are coming up for people to use their lived experience and to speak about it, to share that message with people. So the last thing, our conference this year is themed around, care and choice and community. So I was wondering if you're comfortable, if any of you would want to share kind of what's your self-care, what's your number one go-to self-care strategy when you've had a really hard day in the work that you're doing?
I go out to my garden and I enjoy nature, and I just am grateful that I have a home and that I can just enjoy the flowers and the plants, and that's my self-care and my devotion and doing my devotions. Yep.
For me, it's always been, even when I used to work with the health department, just sitting in my car, lay back, put on some music and chill before I pull off. I don't care if it's 10, 15 minutes. I just got to put myself in a whole different zone and just leave everything on the job that happened on the job. So I don't take nothing home with me. I don't have to do anything. The wife don't have to take it with me. The kids, nobody. I'm gonna leave everything there with these last few Biggie Small songs, and then I'll be all right.
I try to get my cat to hang out with me if at all possible, but that doesn't always work. So knitting is another really big go-to for me, or meditation. But the cat is the number one option, but he has to participate in that activity. So there has to be an option 2 and 3 as well. So yeah, I'd say knitting or meditation are things that I try to do on a regular basis.
Having options, right? Multiple options. That is the name of the game. Well, from my heart, really, thank you all for taking the time to gather together today to share your insight with our community. I wish you the very best in everything that you're doing, and hope that you get lots of time for self-care this summer. Have just a wonderful season ahead, and I hope that that we all get together in person sometime soon. So take care. Thank you so much.
Bye-bye.
Bye.